Cancer, one of the most dreadful diseases for mankind that can affect almost anyone and everyone, might cripple them for a lifetime. Is there a way to prevent them? Is there a way to cure them? Luckily, yes. Cancer could be cured if we were able to identify them at an early stage. Knowledge on biochemical markers allows us to predict the cancerous growth in early stage and save thousands of lives. I request Dr. N. Salvaraj sir, Associate Professor, Department of Surgical Oncology, Coimbatore Medical College, to introduce the speaker and chair the session. The speaker for this session, Dr. M.Prabagar sir.
I welcome everyone to the postprandial presentation. Hope everyone is awake. So it's an interesting, awakening topic, I hope, to the audience. Tumor markers. What is tumor markers? What is the clinical utility of these tumor markers? It is going to be best explained by none other than our professor and HOD of medical oncology, Coimbatore Medical College, Dr. M.Prabagar sir. I welcome you, sir. He completed his MBBS in Madurai Medical College in 1992, completed MD General Medicine in 1997 at Stanley Medical College, Chennai, and he completed DM Medical Oncology in 2008 in Madras Medical College at Chennai, and he was practicing as a consultant physician at Authur till 2005, and now he is working as professor and head of the department medical oncology. He is interested in molecular oncology, biologic therapies, pain, palliative medicine, chemoradiation, breast and thoracic oncology, chronic leukemia, indolent lymphoma, personalized medicine in cancer, and all of more than that, he is a good clinician. And because of his polite approach to the patient, now we have 3 to 4-fold increase in our OPD in our college. And I welcome you, sir, to present on the topic tumor marker.
Thank you, sir, for your nice introduction. And I thank Professor Devalakshmi Madam for giving this opportunity to stand before you and share my thoughts about the tumor markers. Next slide. Next slide, please. So we all know cell is the basic structural and functional unit of every life. And groups of identical cells organized together to perform a particular function. They are known as the tissues. And various tissues grouped together to perform a common function. They are called the organ or organ system. Next slide. Next slide, please. So there are two important things in the growth of a normal cell. So one is the differentiation and another one is the proliferation. We all know we all developed from a single cell. So that single cell has different multiple cells, different cells in our body. So that is the main important function of a cell. So it differentiates from an immature cell to a mature functional cell. For example, pluripotent cells will differentiate into a myeloid series or lymphoid series, erythroids and megakaryocytes will ultimately mature into a WBC, RBC or platelets. Like that, the differentiation is an important aspect. And another cell is the proliferation. So each cell has to proliferate, increase, divide and increase in number. That is called the cell division. Next slide. So both these processes, differentiation as well as the cell proliferation, has to be highly controlled. It should be a highly controlled manner. And these are controlled by various genes. When there is a good control only, we will have a normal tissue as well as a normal structure. And it will have a normal function. When a normal cell loses its ability in its control over the differentiation or proliferation, we will get a transformed cell, otherwise called as a cancer cell. Next slide. So we all know cancer is an abnormal, uncontrolled proliferation of a cell that leads to a tissue and organ dysfunction, system failure, and ultimately leads to death. The development of cancer is a multi-step process, and it involves the gradual loss of the biological control over the cell division. And the cancer transformation, it occurs in a single cell because of some genetic changes that occurs within the cell, which transform a normal cell into a cancerous cell. Next slide, please. So the targets for a normal cell to transform into malignant cells are mainly two. The group of genes that is responsible for the development of cancer can be grouped into two, namely the proto-oncology genes and the tumor suppressor genes. The proto-oncology is actually a normal cell, which normal genes which control the normal cell division of a cell. When there is any mutation like point mutation, deletion, translocations, or fusions, the proto-oncogenes will turn into an oncogene. So these oncogenes will produce abnormal cells, which defies the normal physiological control. So and the next set of genes are called the tumor suppressor gene. The name itself implies it suppresses a abnormal cell division. When there is any genetic alteration in these genes, the cell will grow abnormally. Next slide. So these are the characteristics of the cancer. That is, the entire cancer tumor usually arises from a single cell that is monoclonal in origin. And it will fail to respond to any regulation. Normally, a cell will start growing when there is any signal for it to grow, and it will stop growing when there is a signal to stop it. Whereas the malignant cells will not obey these commands, and it will continuously grow or proliferate. And it has an autonomous growth. It does not need any signals for it to stimulate to grow or proliferation. So it is having an autonomous function. And whenever there is any abnormalities in the cells is there, and our cell is automatically programmed to undergo self-destruction, that is called apoptosis. Whereas the cancer cells will evade this apoptosis. So they will escape apoptosis. So they will keep on surviving. And they are able to invade the adjacent structures, and they are able to produce their own blood supply. There is angiogenesis. And normally, if you say a cell will confine to its anatomical location, for example, a liver cell will remain within the liver only. It will not go out of the liver. Whereas if a liver cell will become a cancer, hepatocellular carcinoma, it will have the tendency to leave the liver and enter into the blood circulation. It will circulate in the circulation. It may get deposited anywhere in our body, like lung, bone, brain, and start growing a separate tumor. So that is called the metastasis property. Next slide. So some 20 or 30 years ago, a mere diagnosis of cancer is nothing less than a death sentence. Your treating physician, when he reads a pathology report as carcinoma, immediately will tell the relatives, nothing can be done. Pray to the God, keep the patient happy till he dies, till he or she dies. So that was the pronouncement by the physician. But the field of oncology has developed so much over the past 2 or 3 decades. Now, most of the cancers can be cured. But one important thing for achieving cure is we have to diagnose the cancer at an early stage. Even after diagnosing, we have to accurately stage the disease, and we have to prognosticate the disease. So after staging and prognostication, we have to plan appropriate treatment. If the patient is having a low risk cancers or less aggressive cancer, we can give standard chemotherapy. And more aggressive or advanced cancers, we may have to give intensified treatment or high dose chemotherapy has to be given. And even if the cancer is diagnosed in stage 4, with the help of chemotherapy, targeted therapy, and immunotherapies nowadays, we can make the patient live for more than 5 to 7 years. So for that, these are the things these are the challenges that stands before the oncologist. There is one early detection. That is, the patient has to be educated about the symptoms of the cancer, and he should be encouraged to report it as early as possible. And even going ahead, that is, we have to diagnose the cancer in a asymptomatic individuals. That is called the screening. And we have to assess whether the tumor is aggressive or non-aggressive. Then we have to assess the prognosis of the disease, whether it's having a good prognosis or bad prognosis. And after giving treatment, we have to ensure the patient is cured of the disease. Even though the patient is cured of the disease, he has the tendency to recur even after 10 or 15 years of time. So we must have some methods to keep the patient under follow, whether the patient recurs or not. Next slide, please. So these important challenges are met with the help of two important departments, which helped immensely in the development of oncology. One is the radiology, which they have started from X-rays. Now we have developed up to the PETs. And next important department we heavily rely upon is the biochemistry department. So the biochemists are developing day by day every substances as well as newer diagnostic methods, which help us to tide over this important crisis in the management of cancer. Next slide. So these substances are called the cancer markers or tumor markers. So what is a tumor markers? So it is a substance produced in or produced by a tumor. By tumor, it may be a benign tumor or a malignant tumor, may give rise to a specific substance. Or it may be produced by a body in response to the presence of a tumor. And we can differentiate with the use of tumor markers, we can differentiate a tumor from a normal cells. And these tumors can be found in blood, urine, or any other body fluid, or it can be found on the surface of a cancer cell. Next slide, please. So some historical facts. So the tumor markers have been found way back in 1846, where the Benz-Jones has identified the BJP, that is Benz-Jones protein, in the patients of multiple myeloma. So in 1930s and 1960s, we had acid phosphatase, which served as a marker for the presence of prostate cancer. In 1960, we had the diagnostic test called the radioimmunoassay. And 1960 and 65, we have alpha-fetoprotein and carcinoembryonic antigen, which are helpful in hepatocellular carcinoma and colon cancer, respectively. Next slide, please. So in 1975, monoclonal antibody techniques were available. With that, we were able to identify certain special tumor markers like cancer antigen 125, 15.3, or 19.9. In 1990, we had PSA, that is prostate specific antigen. And in 1970s to 1980s, the new concepts of oncogenes and the tumor suppressor gene, which we have discussed earlier, have come into existence only in the 1970s and 80s. And in 2000s, we have various diagnostics techniques like microarrays, mass spectrometry, neural networks, and multi-parameter analysis are available. Next slide. So before going to the tumor marker, we must look for the properties of an ideal tumor markers. So the tumor markers should be highly sensitive. That is, it should be detectable in an early stage of tumor. And it should be highly specific, should be present in a particular tumor only. It should be accurate in differentiating healthy individual from tumor patients. And it should differentiate between neoplastic from non-neoplastic, malignant from non-malignant tumors. And you should have a positive correlation with the tumor volume on the stage of the disease. So in stage 1 or stage 2, it have a low level, and stage 3 or 4 should have a high level. That sort of correlation should be there. Next slide, please. Should have a predictive value, that is, whether a particular chemotherapy agent or a hormone will act on the tumor. We can use it, that is called the predictive value, and prognostic value to identify the aggressiveness of the tumor. Prognostic value is important. And the level of this tumor marker should be present even before the onset of the cancer. So that's what Madam said. In diabetes, even before the diagnosis of diabetes, we need some markers for persons who are predisposed to development of diabetes like that. So the markers should be found in a normal individual so that it can be used for screening. And of course, it should be easily accessible, reliable, repeatable, and important point, it should be affordable to the patients. Next slide, please. So various testing methods are available for tumor markers like simple biochemical methods, or we have immunological tests like ELISA, microenzyme immunoassay, this IRMA, that is imatinib resistant mutation analysis, radio immunoassay, and we have immunohistochemical markers like estrogen receptor, progesterone receptor, HER2, and Ki67. These markers can be identified by immunohistochemical methods. And we have molecular and biological techniques, which like FISH, RT-PCR, and HPLC to identify various tumor markers. Next slide. So what are the clinical application of the tumor markers? Next slide. So the tumor markers can be used as a screening, that is diagnosing a cancer in an asymptomatic individuals. So, but unfortunately, the tumor markers role as a screening tool is very limited because it is relatively low in sensitivity, it lacks specificity, it may not be elevated in early stages, and we cannot detect tumor markers in carcinoma in situ, that is before the tumor become invasive, these tumor markers may not be elevated. But it can be used in limited areas like alpha-fetoprotein is used as a screening tool in China to diagnose liver cancer, and urinary vinyl mandelic acid and homovanillic acid are used to diagnose neuroblastoma in Japanese children, and prostate-specific antigen along with digital rectal examination above 50 years of age is useful to diagnose CA prostate. Next slide. Tumor markers in making a diagnosis. So once again, it is lacks its credibility as a diagnostic marker because it may be elevated in benign conditions also. It may not be elevated in every person with cancer, especially in early stages of the disease. And many markers are not specific to a particular tumor. We will see it in the later slides. And one marker can be elevated in more than one cancers. So with the one marker, we cannot say from which cancer it has arisen. But it can be used as a complementary to a clinical findings as well as a radiological finding to diagnose, especially alpha-fetoprotein hepatocellular carcinoma. If a CT scan showing a mass in the liver, which characteristic features, if it is having a raised alpha-fetoprotein, it may indicate it is a hepatocellular carcinoma. Now this point has been removed. We cannot use alpha-fetoprotein for diagnosis. We have to use cirrhosis as well as the hepatitis B and hepatitis C presence to make a diagnosis of hepatocellular carcinoma even without biopsy. Next slide, please. So, next, it has a role in staging as well as prognosticating the tumors. So its role is main in this two process, that is prognostic factors. So because the level of tumor usually correlates with the metabolic activity of a tumor. So highly metabolic cells is it means it's a highly aggressive tumor. It will have a high tumor marker levels, and it will usually correlates with the tumor size, and it also correlates with the invasion. For example, if the PSA is high, then the Gleason score, the grade of the tumor also will be high. And estrogen and progesterone receptors, if it is positive on a breast cancer, we can say the patient's he's having a good prognosis. And HER2 new receptors are expressed on the breast cancer cells, we can say the patient is having a bad prognostic disease. So, and it is also helpful to risk stratify and work out therapeutic strategy, especially in lymphomas and leukemias. We have to risk stratify whether the patient falls into low risk, intermediate risk, or high risk category. And if he's a low risk or intermediate risk, we can be a little soft on the treatment by giving standard chemotherapy. If it is a high risk disease, then we have to intensify our treatment by giving high dose chemotherapy or even going up to the stem cell transplant. Next slide. Another important thing is this is I will say this is the most important aspect of a tumor markers to assess response to treatment. So especially nowadays we are giving chemotherapy to breast cancer and ovarian cancer to reduce the size of the tumor. So to know whether the tumor is responding to a particular treatment or chemotherapy regimen, then we have to measure the tumor markers which was elevated previously, if it start falling, we can say the tumor is responding to the treatment. And certain tumors will completely disappear if we have completely treated the patients, like in the case of after a surgery, like in prostate or in ovary, and the relevant markers will completely disappear. Even in advanced cases, if you are giving, like I said, in chemotherapy response assessment also, it is useful. Next slide. And monitoring and detecting early recurrence is another aspect of usefulness of these tumor markers. So for that, we have to do a serial testing of these tumor markers. If tumor markers, which has become completely normal after a successful treatment, if it starts rising, it indicates the tumor is recurring somewhere in the body. For example, the PSA, like I said, after a radical prostatectomy or radiotherapy to the prostate, the elevated PSA level will become normal. Another important thing is the gestational thromboplastic, that is this mole or invasive mole will have a high levels of beta HCG. After suction evacuation, or in some cases after chemotherapy, the beta HCG will completely fall into a undetectable or normal, very minimal levels. And CA125 is used in the response assessment for the ovarian cancer recurrence. So ovarian cancer, we do a staging laparotomy and give chemotherapy and follow the patient with CA125. And the CA125 will be within the normals, that is less than 35 international units. If it is start rising, then we have to evaluate for the presence of recurrence. Next slide, please. So we have to take some precautions while ordering the tumor markers. One is we should not rely on one level. We have to monitor the tumor markers serially. And while repeating the tumor markers, it is better to do a tumor markers in the same lab, preferably with the same kit. And we should be sure that the tumor markers is elevated before the surgery. Then only we can assess upon this common knowledge. And before taking a tumor marker for follow-up, we have to know about the metabolism, excretion, as well as the half-life of tumor markers. We all should consider. And it is better to do multiple markers for one tumor for follow-up. Next slide. Now, classification of tumor markers. So originally, we used to think the tumor markers are only proteins. Now, various various substances are found to be useful as tumor markers. Next slide, please. Next slide, please. So the tumor markers, certain enzymes can be used as a tumor markers, like in case of alkaline phosphatase. Alkaline ALP is elevated in primary liver cancers or any cancer which has spread to the liver, liver metastasis also, the alkaline phosphatase will be raised. Another one is the prostate acids phosphatase, PAP, prostatic acids phosphatase. It is elevated in prostatic cancer. It also may be elevated in other cancers like osteogenic sarcoma, multiple myeloma, and bone metastasis. And certain benign conditions also show elevation of PAP, like osteoporosis and hyperparathyroidism. And the third enzyme is the prostate-specific antigen. And it is more specific in prostate screening, detection, as well as monitoring the response in prostate cancer. Next slide, please. Then hormones as tumor markers, we have calcitonin to monitor the response in the case of medullary carcinoma of thyroid. And like I said, human chorionic gonadotropin, especially the beta subunit, beta HCG, is highly elevated in gestational trophoblastic disease, as well as germ cell tumors of testis, as well as ovary. And it will disappear completely after successful treatment, and it will be useful as follow-up to rule out a recurrence. And inhibin, it's also a peptide hormone. It is normally produced by an ovarian granuloma cell, and it is elevated in granulosa cell tumor of the ovary, which is a little rare ovarian cancer. Normally, the ovaries, the commonest cancer is the epithelial ovarian cancer. We have granulosa cell tumor, theca cell tumors, that is called interstitial tumors, as well as we have germ cell tumors. So for epithelial ovarian cancer, we have CA125, and for granulosa cell tumors, we have a marker called inhibin. Next slide, please. Next slide. So we have oncofetal antigens like alpha fetoprotein and carcinoembryonic antigen. Next slide. So alpha fetoprotein is a 70 kilodalton glycoprotein, which is homologous to albumin. It is synthesized in the fetal liver, yolk sac, and gastrointestinal tract. And it is usually seen in the fetal period. Its peak is seen in the 3rd month of gestation. And after the delivery of a baby, it will start decreasing. And normal adult level will be less than 20 nanograms. And it has a half-life of 3.5 days. Next slide, please. So the alpha beta protein may be elevated in malignancies like hepatocellular carcinomas, non-seminomatous germ cell tumors of testis, and hepatoblastoma, and certain adenocarcinomas from lung or GI tract or stomach may also show a rise in alpha beta protein. And this AFP may be raised in certain benign conditions also, like hepatitis, cirrhosis, biliary tract obstruction, certain metabolic conditions like ataxia, hereditary tyrosinemia, and anatomical complications like ataxia, telangiectasia. Next slide, please. So it can be, alpha beta can be used for screening of hepatocellular carcinoma, especially the patient who are running high risk for hepatocellular carcinoma, like patient who are having cirrhosis or having hepatitis B, chronic hepatitis B or C infections. And it will aid in the diagnosis of hepatocellular carcinoma and hepatoblastoma. And it is an independent prognostic marker for non-seminomatous germ cell tumors. Alpha beta protein level above 10,000 is considered to be highly aggressive. Next slide, please. Next slide, please. So it is also elevated in colorectal cancers. Sorry, the title is CEA. CEA is the elevated in, title is not, oh yes, next slide. Thank you. So next embryonic antigen is the carcinoembryonic antigen. So it is a set of glycoprotein. It is involved in the cell adhesion. So it is normally produced in gastrointestinal tissues, and during it is present only in the fetal life and start decreasing after delivery of a baby, and the normal level is even less than the alpha beta protein, that is 2 to 4 nanogram per ml. Next slide, please. Please. So it is elevated in colorectal cancer, and it is also useful as a tool for response assessment, and it is also used to identify the recurrences. And the CEA is not specific. It may be raised in gastric, pancreatic, lung, and breast cancer. Even in thyroid cancer also, this carcinoembryonic antigen may be elevated. And it is elevated in some non-neoplastic conditions like ulcerative colitis, pancreatitis, cirrhosis, and even chronic smokers. Next slide, please. So next we have a carbohydrate markers, the carcinoma antigen 53, which is a marker for breast cancer. It is also present in pancreatic, liver, lung, colorectal, as well as ovarian cancers. And it is also elevated in certain benign breast as well as liver conditions. Next slide. Next slide. So CA125, this is one of the common marker we use day in, day out in to diagnose as well as monitor response in the case of CA ovary, epithelial ovarian cancers. But it is very unreliable because the sensitivity may be adequate, but it lacks specificity. It may be elevated in benign conditions. It may be elevated in physiological as well as in pathological conditions. Even in pathological conditions, may be elevated in benign as well as malignant conditions. In ovarian malignancies and other malignancies also, it may be elevated. So it is highly non-specific. The next marker is the CA199, which is elevated in pancreatic as well as hepatobiliary malignancies. And colorectal, gastric, and breast cancer also will show elevation of CA199. And benign conditions like pancreatitis and gastrointestinal disease, we can have elevation of CA199. That's why I said most of the tumor markers lack specificity. Next slide, please. So receptor markers, this is another important, not almost, 100% of the breast cancer patients has to undergo these investigations, namely the receptor markers, estrogen and progesterone receptors. So we use it in breast cancer. It is used as a predictive factor. That is, we can say whether a breast cancer tumor patient can be treated with hormones like tamoxifen in the case of premenopausal women or aromatase inhibitors in case of a postmenopausal woman. And it also used as a prognostic factor. Those breast cancer patients who are positive for estrogen as well as progesterone receptors tend to be fare well and they will respond well to our treatment than those who lack these receptors. Next slide. Then we have protein markers. Proteins as tumor markers, namely the beta-2 microglobulin, like we already seen in a nephrology talk. The beta-2 microglobulin may be elevated in multiple myeloma, Hodgkin's lymphoma, and it also influences in oncological conditions like chronic inflammation as well as viral hepatitis. And ferritin is a marker of hematological malignancies like Hodgkin's lymphoma and leukemia. And certain solid cancers like liver, lung, breast cancer also show an elevation of ferritin. And thyroglobulin is a useful marker for detection of differentiated thyroid cancer like follicular or papillary thyroid carcinoma after radical thyroidectomy and iodine ablation. We can follow the patient with thyroglobulin. And immunoglobulin, Benson's protein, like in nephrology talk, we see a light chain disease. These proteins can be found in urine and it is a marker for plasma cell neoplasms, especially the multiple myeloma. Next slide, please. Then growth factors can also be used as tumor markers, like the transforming growth factor beta as well as alpha. They are raised in hepatocellular carcinoma and invasive bladder cancer will have a raised TGF. TGF alpha, it is useful in screening, especially the persons who are having asbestosis. If the TGF alpha is raised, the patients who are having asbestosis, then we can say the patient is going to develop lung cancer in the future. Next slide, please. Then platelet-derived growth factor, it is significantly elevated in about 15% of patients with carcinomas, sarcomas, and lymphomas. And the serum level significantly correlates with the stage of the disease, especially the breast cancer. And higher levels predict shorter survivals. Next marker is the fibroblast growth factor, which is elevated in about 50% of patients with renal cell carcinomas. It is also elevated in CNS, lung cancers, as well as lymphomas. And if the FGF beta fraction of FGF is recently elevated in a patient with a non-small cell lung cancer, it says that the tumor will respond well for the treatment. It's a good prognostic marker. Next slide. Then growth factor receptors also may be used as a tumor markers. One is the epidermal growth factor receptors. This growth factor receptors we use commonly in the case of lung cancers, especially non-squamous lung cancers. There is adenocarcinomas, large cell carcinomas. These tumors will have increased expression of this epidermal growth factor receptors, and we have specific inhibitors for this EGFR, namely the tyrosine kinase inhibitors, namely the geftinib is a one drug. If it is elevated, if we give the geftinib for a adenocarcinoma lung patient, the patient is expected to live for more than 3 to 5 years, even in advanced stages. Next slide. Then another important receptor is the HER2 receptors. This is also we recommendly order for all patients of breast cancer, along with estrogen and progesterone receptors. And these three receptors in various combinations can be used as a prognostic markers. If estrogen receptor and progesterone receptor are positive and HER2 receptor is negative, it is going to be the best prognosis. And if all these things are negative, we call it the triple negative breast cancers, and that will have the worst prognosis. Generally, if HER2 is positive, the prognosis is bad than the HER2 negative tumors. Nowadays, the HER2 is elevated in lung, colorectal, as well as ovarian cancers. So those patients, not only breast cancers, the lung cancers, as well as ovarian and colorectal cancer, if they are having elevated HER2 receptors on the surface of the cancer cells, and we have specific anti-HER2 agents, namely the trastuzumab is available. When you give trastuzumab, it will goes specifically and attack the cells which are positive for the HER2 receptors and produces a good response to these tumors which are expressing these receptors. Next slide. And certain oncogenes also can be used as tumor markers like RAS, MYC, and ABL, BCR. BCR, ABL is another important thing which has revolutionized the treatment of chronic myeloid leukemia. Previously, chronic myeloid leukemia, we used to give hydroxyurea, and if we want a cure, we have to go for the stem cell transplant. Nowadays, if the patient is having, almost 99% will be having this mutation, BCR, ABL mutation, and we have specific drugs like imatinib, dasatinib, nilotinib and various other drugs are available, which specifically acts on this mutation BCR-ABL, and the patients can have a near normal life without transplantation. And we have tumor suppressor genes like BRCA1, P53, and retinoblastoma genes. This can be used as a marker for genetic tumors, and we can take precautionary measures for those persons who are having these mutations. For BRCA, we have two BRCA genes, namely the BRCA1 and 2. If they are mutated, they are running a higher risk for the development of breast, ovary, endometrial, pancreatic, and colorectal cancers. And in Western countries, even nowadays, even I have seen in a GH patient who was positive for BRCA1 and BRCA mutation, she has undergone bilateral mastectomy, prophylactic bilateral mastectomy. So which we have seen some 10 years ago in the form of Angelina Jolie, the Jolie effect, which was taking the whole world by storm, which was not catching up in India, but slowly it is catching up in India too. So we have seen, I'm actually really surprised to see a patient with a low socioeconomic status and low IQ. She has undergone a bilateral mastectomy just for prophylaxis of breast cancer. Next slide, please. So the c-MYC encoded protein, that is P62, it is overexpressed in Burkitt's lymphoma. Burkitt's lymphoma is one type of non-Hodgkin's lymphoma. We have various subtypes of non-Hodgkin's lymphomas. Non-Hodgkin's lymphoma may, the behavior may vary, may be indolent, there may be normal behavior, or there may be aggressive. And Burkitt's lymphoma is one non-Hodgkin lymphoma of aggressive type. So if the c-MYC or P62 is elevated, then we can diagnose an NHL as Burkitt lymphoma, and we have to give a high dose chemotherapy. And it is also elevated in breast as well as in colon cancer, and it is useful for follow-up of the tumor also. And anti-c-MYC antibodies are found elevated in patients having colorectal cancers, chronic myeloid leukemias, and Burkitt lymphomas. Next slide. Then another gene is the P53. It is increase in hepatocellular carcinoma cirrhosis of patients. It is having a, if it is elevated, it shows a poor risk in patients who are having hepatocellular carcinoma. If it is elevated in patients who are having cirrhosis of the liver, and that means like in aspartosis, it is also the carcinogenesis in the indicator for carcinoma in the making. And if P53 is elevated in breast cancer, it is associated with aggressive disease, and the survival is going to be worse. And mutant 53 also found in it is cells which are shed in the urine, so they can be used as a screening tool for the diagnosis of bladder cancer. And antibodies for this P53 are found in ovarian, colon, lung, and breast cancer, and they are marker for early detection in oral cancers, which is very common cancers among Indian males. Next slide, please. So nuclear matrix proteins is another genetic material which can be used in to diagnose cancer bladder. It is tested by ELISA methods. It has a high sensitivity and specificity. That's why US FDA has approved NMP22 protein for follow-up for bladder cancer. Next slide. So far we have talked about the markers. Now we will see the common cancers and their associated tumor markers. Next slide, please. So the breast cancer is the important cancer, which is the commonest cancer world over, irrespective of age and sex. And in India, it is the commonest cancer among the women. It has overtaken the CA cervix. Now for CA breast cancer, as already said, we have to order these three markers, estrogen receptors, progesterone receptors, and HER2 receptors. Nowadays, we have to go for the BRCA testing also to know about the genetic predisposition of this breast cancer. So I said the aggressiveness can be assessed by the permutation combination of positivity of these three receptors, and it will helpful to decide the treatment. If the patient is having ER/PR positive, we can treat the patient with hormones. If HER2 receptor is positive, we can give anti-HER2 treatment like trastuzumab. And these markers can be tested by simple immunohistochemistry, FISH or RT-PCR. Next slide, please. Then in breast cancer, the CA15-3 and CA27.29 may also be elevated. They are used as monitoring for therapy in patients who are having advanced diseases. And one study has shown that CA2729 was highly specific and sensitive in detecting preclinical metastasis, not clinical primary, but preclinical metastasis can be identified with the help of CA2729. And this can be tested by ELISA and monoclonal antibodies radioimmunoassay. Next slide. Next we see colorectal cancers. We have two markers for colorectal cancers, namely the carcinoembryonic antigen and CA19-9. And elevated CA level before surgery may indicate the disease is going to have a bad prognosis. And if the tumor is completely removed by surgery, then the CA levels will fall within normal levels within 4 to 6 weeks. And we have to follow the patient with the help of CEA once in 3 to 6 months. If it start elevating, then we can say it is recurrent. Certain early recurrences, once again, can be cured with the help of surgery. Next slide, please. For liver cancers, we have alpha-fetoprotein. It can be used for screening, periodic screening along with ultrasound abdomen is useful to diagnose liver cancer at an early stage. And AFP can be used during follow-up. And previously, as I said, it is used for diagnosis. Nowadays, it's no more used for diagnosis. Next slide. Then for prostatic cancer, we have prostate-specific antigen. And the PSA level more than 4 nanogram per liter suggests the presence of prostatic cancer. If it is elevated more than 10 nanogram per ml, then the suspicion of prostatic cancer is very strong, and it is useful to assess the response. So post-surgery or radiotherapy, it will fall completely normal. Even advanced stages after chemotherapy or anti-hormone therapy, the PSA level will fall to a normal level. And if you are after surgery, if you are following the patient with the PSA, or if you are treating with the one agent, if the PSA which has fallen to normal level, it starts rising, that means we have to look for the recurrence or we have to change the treatment. Next slide, please. And ovarian cancer, like I said, we have CA125 for epithelial ovarian cancer, and we have beta-HCG and alpha-fetoprotein useful to diagnose germ cell tumors of ovary. Next slide. And for testicular cancers, we have 3 markers, namely the beta-HCG, alpha-fetoprotein, and LDH. And LDH is a non-specific marker, so usually we don't bother about. If the other things are normal, elevated LDH, we don't bother. So the 2 important markers are the beta-HCG as well as alpha-fetoprotein. It is usually elevated in non-seminomas only. It is normally not elevated in seminomas. If it is elevated in seminoma, then we have to consider, we cannot consider it as a pure seminoma. We have to consider it as a mixed germ cell tumor. And non-seminoma, more than 50% of the patients, it will be elevated even in early stage of the disease. And in choriocarcinoma, the beta-HCG level alone will be elevated, whereas the alpha-fetoprotein will be normal. Whereas in yolk sac and endodermal sinus tumor of the testis, the reversal happens. The alpha-fetoprotein rises, whereas the beta-HCG remains within normal limits. Next slide, please. So these are a nutshell, the tumor markers in certain tumors like in hepatoma, we have alpha-fetoprotein. In ovarian cancer, we have CA125 and we have BRCA2 mutation, and we have, like I said, beta-HCG, alpha-fetoprotein and inhibin. For breast cancer, we have CA15-3, CEA, HER2, estrogen progesterone receptors, and BRCA1 and BRCA2 mutations. Next slide. And for cancer of pancreas, we have CA19-9 and CEA. And for colorectal cancer, once again, we have CEA first and CA19-9. We can see for head and neck, CA19-9 is important and CEA is secondary, whereas colorectal cancer, CEA is primary and CA19-9 is secondary. And for pheochromocytoma, we can use urinary vinyl mandelic acid. And non-seminal-metastatic gliomas, we have alpha-beta protein and beta-HCG. And gestational trophoblastic neoplasms, that is called vesicular mole or choriocarcinoma, we have beta-HCG. And for prostatic cancer, we have PSA. Next slide. Next slide, please. So to summarize, so the tumor markers are substances which are associated with the various stages of cancers. And it has actually revolutionized the way we approach the cancers. And it may have a limited role as a diagnostic, as a screening tool, but it is very useful in prognosticating, to assess the response, to ensure cure, and to look for the recurrence. It's very useful. And the role in screening and early detections are still limited. And day by day, new tumor markers are on the making. And the search for an ideal tumor marker still goes on. Thank you. Thank you for your patient listening.
Thank you, sir, for presenting the tumor marker in detail. And you have explained the entire spectrum of utility and everything about the tumor markers. And hope the students understood about the history, classification, various utility in the diagnosis and other aspects of the cancer management. And if you get an short notes, definitely you can write the basic points in all tumor markers, like it is helpful for diagnosis. It is helpful to understand the staging and virulence, aggressiveness of the tumor. And it helps to guide the treatment, like selecting the drugs. And it helps to identify the response to the treatment. And also it helps to detect the yearly recurrence. So these points you can write in any tumor markers and you can get the mark easily. And thank you, sir, for this wonderful presentation.
Thank you, sir. That was a
So we are-
truly captivating session.
Just a minute. Though we are known to be frequently associated with pathologists for pathologists in histopathological documentation, our association with pathologists may be only once at the time of diagnosis, maybe very rarely at the time of recurrence. And our association with radiologists also limited, maybe once in 6 months. And our oncologist association with the Department of Biochemistry is almost day in, day out. So our association biochemistry department is more than the pathologists as well as the radiologists. And I am very thankful for the biochemistry department in helping us to manage the cancer patients.
Thank you, sir. That was a truly captivating session. Now I call upon the chairperson, Dr. N. Selvaraj, sir, to felicitate the speaker. Thank you, sir. I request our HOD Dr. N. Debalakshmi ma'am, to felicitate the chairperson.
Thank you, ma'am. So